All right, so I think we're ready to go. My name is Richard Leake. I'm one of the musculoskeletal radiologists. Been an attending for a little over 2 years. I know Amanda showed the picture. We're all a pretty young section, so we like to work with medical students, residents, fellows, and we really like education. So my topic today is fractures, and so there's a lot of different things about fractures. We're going to talk about nomenclature, and then I'm going to go over some common fractures. But to start, we're just going to go over just a few quiz questions. These are not the quiz questions for the course, but we're going to use Poll Everywhere. So I'm just showing these images kind of just as a beginning, and then here's the Poll Everywhere question. Oh, maybe. Very touchy today. So my Poll Everywhere. Okay, we're going to be really touchy. Okay. So this is just an identify the abnormality. If you can just identify the abnormality, I put my my account, Richard Leake 312, at the top. Okay, so yeah, most everybody's getting it right in that area. So this is a posterior shoulder dislocation with a reverse heel sacs. And there's the region of interest. Most everybody got it. I mean, I should have drawn it bigger. All right, good job, everybody. So we'll go to the next one. And that's just an image, and then here's the image with the question. All right, and then the correct answer is fibula, and that's this fracture. Let me get the pointer on. Laser pointer. This fracture, all right, right here. You can't see that, but this is the fibula. All right, and then the next question is going to be, what is the name of this fracture? Deactivated it. All right, and this is the Colles fracture. Smith's would be the opposite. And the next question. Identify the fractured bone. All right, everybody's getting this one really well. It's a radial head fracture. Okay. There's this. Okay, and then last one, I think. So which bone is fractured here? All right. And this is a tibial plateau fracture. So That's correct. All right, so the objectives, we're going to understand the basic anatomic terms related to the extremities, gain a better knowledge base of fracture terminology is used by MSK radiologists, identify common fractures, some of which have eponyms, and then complete a 5-question quiz at the end of the lecture. So we'll start with the anatomic terms, then fracture basics, then review the common fractures, and then the quiz. All right. I know Amanda already did this, so because I watched her lecture. So if you guys want to do this, we can, or we can skip it. I know that you guys are all doing a bunch of different things, which is good. I personally am super biased towards radiology, but that's one of the great parts about medicine. A lot of different things. Who's doing naturopathy? I like that. IR. Neurology, psych, medicine, essential oils. I like that too. Excellent. Okay. So for everybody, almost anybody who's going to be doing anything is going to need to know about fractures, because you're either going to do a residency where you're going to deal with it, or you're going to do an intern year where you're probably going to have to deal with it. So for anatomic terms, I know Amanda kind of talked about a little bit, but our terms are based upon anatomical position. So that's like this figure here with the palms up. So radial, the thumbs, the radial side is lateral, and the pinky side is medial. But when we're talking in the hands, we just say radial or ulnar, just so we don't get confused. Volar is anterior, so that's the palm side of the hands. Dorsal is posterior, so that's the back of the hands. In the foot, dorsal is a little bit confusing because it's the top of the foot, and plantar is the bottom of the foot. And then when we're talking about cross-sectional imaging where it says transverse plane, we refer to this as the axial plane. So when we're talking fractures, anatomic terms in location are kind of important. So next. So basics. So first thing, the most important thing we're talking about a fracture is the location. It's like real estate. Location, location, location. So we want to know which bone it is. We want to know where in the bone it is. So like Amanda, I discussed it as proximal, mid, and distal. And then we want to know if there's intra-articular extension or not. And then we talk about directions of fractures. So we have transverse fractures, we have oblique fractures, and then we have spiral fractures, which are very similar to oblique. And then we talk about comminution, or whether the fracture is comminuted. And a comminuted fracture is a fracture with 3 or more fracture fragments, or 2 or more fragments, depending on what we want to talk about. So this fracture here of the femur this is the proximal femur, this is the distal part of the femur, and this is a butterfly fragment right here. And it's a wedge-shaped fracture. So this has 3 pieces: this bone, and this bone, and maybe some smaller ones. So this is a comminuted fracture with a specific name of fragmentation being a butterfly. And then we also talk about segmental fractures. And segmental fractures we really worry about in the ribs, because if you have a segmental fracture, that's where a piece of bone is just floating free. Then you can get a flail chest. All right, so let's answer this question. If you guys can just tell me what's the direction of the fracture. Is it transverse, oblique, or spiral? So first you have to identify the fracture and then decide what is the direction. All right, so this actually is a transverse fracture. So here's the slide showing it. So here on this lateral view, which again, I only gave you one view, and I know Amanda said one view is no view. So here's where the 3 views of the foot are helpful. On the lateral view, we see this fracture is almost vertical here. On the AP, we're seeing the fracture go transverse across here. On the oblique, it does have somewhat, the oblique view, it does look somewhat oblique. But on all 4 views, or all 3 views in combination, it looks more like a transverse fracture. But if you described it as an oblique fracture, it wouldn't be the end of the world. For simple fractures like this, where there's just one fracture, it's not really that important, but we just use it for descriptors. Here's another example of a transverse fracture. These are some of the hardest fractures to identify, which is a patellar fracture. We see it right here on the lateral view. We see this fracture line going transverse through the inferior pole of the patella. And on the AP view, you really can't see it very well because of all the osteophytes creating more sclerosis around the patella. So when it comes to patellar fractures, we do like to have 3 views. We add the sunrise view or the patellar view, which is taken from the top of the knee and highlights the patella. And that's one where we would see a transverse or longitudinal fracture going up and down in the craniocaudal plane instead of this in the transverse or axial plane. So this is a transverse fracture of the patella. Next, here's a transverse fracture of the base of the ring finger distal phalanx. So when we're talking about phalanx, this is distal phalanx, middle phalanx, proximal phalanx. This is the tuft, when we talk about the tuft in the distal phalanx. When it comes to describing which finger, a lot of orthopedic surgeons like us to name the fingers in the hands. So that would be thumb, index finger, long finger, ring finger, and small finger. Otherwise, you could do first, second, third, fourth, and fifth, with first being the thumb and fifth being the pinky or ring or small finger. So here's an oblique fracture. Compared to that fracture was here in the base of the fifth on that other patient, these are much more angulated here and here in the 4th and 5th metatarsal necks. And then here's another oblique, or even could be described as a spiral fracture of the, well, we have the oblique fracture of the proximal fibula here, and then the spiral fracture here of the tibia. So a spiral fracture is just basically a variant of an oblique fracture, but it has a spiral component as it comes down the bottom. It spirals. And then here's another spiral fracture of the distal humerus. And this kind of gets into some of the things we talked about, which is angulation and displacement. So this is apex lateral angulation and posterior lateral displacement, which we'll talk about more in just a second. And then here's another fracture of the humerus. This is a comminuted fracture of the proximal humerus with fragmentation of the greater and lesser tuberosities, as well as then we can see a displaced fracture of the proximal ulna. So we talk a lot about edge of view or corner fractures. When we talk about that, we're talking about here, this fracture is at the edge of our field of view. And we see this fracture, and it's really comminuted, a lot of displacement, and then we don't want to satisfaction of search and miss any other fractures. So like Amanda said, where there's one fracture, there's usually multiple fractures or 2 fractures, so we have to look everywhere on the images because we're responsible for it. I mean, even here, if there's a lung cancer right here, we're responsible for it as radiologists. And here's another comminuted fracture. So this is comminuted displaced and open fracture of the distal tibia and fibula, and it has an external fixation in place. A lot of comminution, a lot of fracture fragments. There's soft tissue air here, and you've lost skin on both, all on this ankle, so we know that it's an open fracture. All right, and here's another comminuted fracture that shows intra-articular extension. So here's the articular surface, and this fracture goes that articular surface, and that's very important. That can lead to arthritis down the road. And then there's also an ulnar styloid fracture. So basics, when we talk about displacement, we're describing the location of the distal bone in relation to the proximal bone. So on this example right here, this is a comminuted displaced intra-articular fracture of the distal tibia. and it shows lateral displacement. So here's this is the proximal tibia here, and then the distal tibia is displaced laterally this way. And then you can see this line right here coming down to that joint line to the tibial plafond, and that's why it's an intra-articular fracture. So that's when it's just kind of more of a simple fracture. When it's comminuted, we're going to discuss the location of the major fragments. So really we're going to talk about the proximal bone and then the distal fragment. And then if there's a large fragment, we can describe those separately, saying there's a fragment dislocated or displaced laterally or posteriorly or anteriorly or volarly. So here's a fracture of the greater tuberosity of the proximal left femur, and it shows cranial displacement. So right here on the CT, it's coming cranially or towards the head, or cephalad, and then this would be caudal towards the feet. So here on the X-ray, we can see that this bone fragment was once right here, and now it's displacing proximally or centrally. All right, so angulation. So when we're talking about fracture angulation, we're describing the angle of the fracture. And it's kind of confusing because two different forms or terms can be used. One way to describe it is to describe the angular displacement of the distal fragment with respect to the proximal fragment. I don't use that. What I use is I describe the direction of the apex of the fracture angle. So on this case, we have a displaced fifth metacarpal neck fracture with apex dorsal angulation, and this is what we call a boxer's fracture. So here, I kind of drew a line. If this is the fractured metacarpal, the apex of the angle right here is pointing to the back of the hand, or dorsally. If it was like this, then we would call it apex volar. So this is a boxer's fracture. It's an angulated fracture with apex dorsal angulation. So here's another example. This is another Colles fracture. It's a comminuted fracture of the distal radius with apex volar or anterior angulation, like this. So I find this the easiest way to describe it because I just remember the point or the apex of the angle is pointing in one direction, and that's why I use it that way. Otherwise, I'd get confused. Here's some more fractures. So this is a comminuted fracture of the proximal to mid tibia, and it shows apex medial angulation. And the fracture extends from the tibial plateau up here all the way to there. So this is a pretty bad fracture. Then we also see a comminuted fracture of the fibula with apex medial angulation, a large fracture fragment. And then you can see here, once the orthopedic surgeons or the emergency department physicians put a cast or a splint in place, it definitely obscures the bone, and so it can be difficult to see. So a lot of times the first images we'll see, first radiographs we'll see, don't have any casting or splinting, and that does help a lot in the identification of fractures. So here's a distracted fracture. So this is just discussing how much it's pulled apart. So the opposing fracture ends are separated. So here we're seeing this fracture of the calcaneus, and the posterior calcaneus is distracted, or I should say the anterior calcaneus is distracted from the posterior calcaneus right here. And this, after the distraction is most notable along the plantar aspect. And this person does have a lot of soft tissue swelling, so there's a good possibility there's a fracture in the forefoot as well. So fracture impaction, that's when we're talking about a fracture being impacted or forced into the adjacent bone or fragment. So on this fracture, we're seeing an impacted fracture of the distal tibia. So clearly this cortex right here used to meet right here. So we're getting some telescoping of the bone here and impaction here. So that's what we're looking for, impaction. So this bone is shorter than it used to be. And that's what we see with impaction. Here's another impacted fracture. This is a comminuted impacted fracture of the distal femur. We're seeing that it's telescoped in, right? This bone used to connect right here. That bone used to connect to there. And this bone is definitely shorter. Not well seen on this, but we saw in other imaging is that there was actually an impacted fracture of the tibial plateau. And then here we're seeing this lipohemarthrosis right there. So we're seeing the layering fat up here. So this again shows, I think with Brian's lecture from yesterday, that x-rays, while helpful, are not always the best because we're missing this tibial plateau fracture. Luckily, we see the femoral fracture, and we know that this knee is pretty beat up. Other things that we discuss in fracture is overriding fractures. So that's a shortening of the distal fragment, but not impacted or telescoped into the adjacent bone. So these bone fragments are parallel to each other, and we sometimes describe these as like a bayonet apposition. So on this example here, we have a fourth metacarpal fracture, and it's an overriding fracture and bayonet apposition. And when we say bayonet, that's like the bayonet at the end of a gun. So that it's offset but parallel to each other. And a lot of places, our most common overriding fractures are probably in the clavicle. So this is a displaced fracture of the mid-left clavicle with cranial displacement and bayonet apposition. Clavicles are interesting. We're discussing displacement because in reality, this part of the fracture is attached. It's the corticoclavicular ligaments here and the acromioclavicular ligaments here are intact, and the sternoclavicular ligaments are intact. So we think, a lot of times we think of the proximal clavicle as dropping, but it's the distal clavicle that's being elevated cranially. So it's displaced and in bayonet apposition. All right, other things we talk about are avulsions. So an avulsion fracture is a fracture of bone at the site of a ligament attachment or tendon origin insertion. And tendon avulsions of the pelvis are very common in pediatric patients, and sometimes they're missed because we're not thinking about it. So if you're a radiologist or you're taking care of a pediatric patient and they have a snap or feel pain around their pelvis, then you get an x-ray and we look for avulsion fractures like right here, because they'll have their apophyses or bone just come off at tendon origins or insertions. At times, avulsion fractures are secondary signs of other injuries. So in the tibia, we have what's called a Seguin fracture, and that's an avulsion of the lateral tibial plateau, and those are associated with ACL injuries. Avulsion fractures can also be related to capsules, joint capsules. So this is an avulsion of the left anterior superior iliac spine, right here. Here's another avulsion fracture of a finger. So this is an avulsion fracture of the volar base of the small finger distal phalanx with retraction to the level of the PIP joint. So this fragment right here used to be up here. So as the tendon inserts here, it fractured off, and then it displaced all the way here to the level of the PIP joint. So this is going to be a fun surgery to kind of take this bone and tack it down back up here because it's displaced so far. All right. So the next thing we're going to talk about is incomplete fractures. These are fractures in pediatric patients, and it's where only one cortex of the bone is fractured. And this happens in pediatric patients because pediatric patients' bone are flexible, they're much more plastic, where in adults they're rigid. So the most common pediatric fractures that we're going to see are a buckle or a Colles fracture, and that's where we see buckling of the cortex, and it's usually secondary to compression. So in this patient here, we have a little bit of irregularity of the cortex that we see on the oblique view. You can kind of see this irregularity here on the PA view, and then when we get to the lateral view, we see that the anterior cortex or the volar cortex is intact, and then we see the buckling here of the dorsal cortex, and that's why we call it a buckle fracture. It's just basically the bone buckles because it's plastic and it's just getting a compression stresses, and it buckles. So Greenstick fracture is somewhat of a variant, but it's an angulated fracture with bowing of the bone, and only one cortex, and that's on the outer surface of the convex surface, is fractured. And I have an example of that in a minute. So other fractures that we describe are pathologic fractures. So pathologic fracture is a fracture of unhealthy bone. So that would be somebody who has a malignancy or a benign lesion, or a fracture of an infected bone. So in this example, we have a 3.8 centimeter expansile lesion here in the proximal humerus, and it has a non-displaced fracture right there. And then what we call a lot of times in these is we call it a fallen fragment. So this piece of bone right here that we see right there is called a fallen fragment, and that's just going from the cortex down into the bone. And in a patient like this, who's a pediatric patient, this is most likely going to be a non-aggressive lesion, probably something like a unicameral bone cyst or solitary bone cyst or fibroosseous lesion. Here, the next fracture that we're going to talk about is a stress fracture. So this is an abnormal stress on a normal bone. So stress fractures are increased stress on normal bone. So these people have healthy bone. It's common in military recruits and runners. We see them in the metatarsals, in the tibia, in medial tibial stress syndrome, and then in the proximal femur in the femoral necks. And this is usually an incomplete fracture, though they can progress to being a complete fracture. Some of the first signs that we're going to see on radiographs are just going to be periosteal reaction and callus formation, and we won't even see the fracture line on x-rays. If we do an MRI, then we'll see bone edema, this periosteal reaction, and callus formation, and then a fracture line. So here on this, we do see a fracture line right here, and then we see a little periosteal reaction. That's just this little bit of new bone formation here along the anterior tibia. So this is a stress fracture of the mid-tibial diaphysis. And here's an example of a stress fracture in the metatarsal. So here we're seeing this cortical thickening. You see, look at the comparison first and third metatarsal. The cortex is right here. And then you can see here it's definitely thickening along that medial aspect. There's also a little bit of the periosteum coming up here. So that's that periosteal reaction. And then here we do see this incomplete fracture line through the medial aspect of the distal metatarsal. And then we'll get to an insufficiency fracture. So as opposed to a stress fracture, an insufficiency fracture is normal stress on abnormal bone, but not abnormal as in a pathologic fracture with malignancy or infection or a benign lesion. So this is an abnormal bone that's usually due to osteoporosis, or it is due to osteoporosis and osteopenia, or from a metabolic bone disease. So here in this patient, we have an insufficiency fracture of the femoral head. Wow, this is really touchy right now, right here. So normally the femoral head should be nice and round, but here we're starting to see it flatten. We see a little bit of subchondral sclerosis. And so this is an insufficiency fracture of the femoral head. Now, in younger patients or patients who are on a lot of steroids, we'd be concerned that this could also be an avascular necrosis. We don't see a lot of sclerosis under it, which is why this was favored to be an insufficiency fracture as opposed to avascular necrosis, having subchondral collapse. A lot of the insufficiency fractures that we see are in the sacrum because there's a lot of weight bearing and stress that goes into the sacrum. So we look for a Honda sign or classic H sign. So it usually is a fracture of the sacral ala here. And then with a transverse component going through one of the sacral bodies right here. So they're not always the easiest to see on radiographs. We definitely miss these. But when we can get MRI or bone scans, and those definitely help us to identify these. So here's the fracture here. And then this sclerosis here is showing that this is a fracture that's somewhat healing. And then there's a little bit of sclerosis right here in the sacral ala. So again, a stress fracture is a fracture of abnormal stress on normal bone, and an insufficiency fracture is normal stress on an abnormal bone. So kind of the last part of fracture basics is the Salter-Harris fracture classification. And we only use this for pediatric fractures involving the physis. So if somebody has a fused physis, this terminology is not used. So the first is a type 1 fracture, and that's just a fracture of the growth plate. And these are really hard to diagnose on imaging, and probably more of a clinical diagnosis. A fracture type 2 is through the growth plate and the metaphysis. The type 3 is through the growth plate and the epiphysis. And type 4 is through all three elements. So the metaphysis is here. Then we have the physis, and then we have the epiphysis. So this is showing it on the distal bone, right? But on the proximal bone, you just flip it, and the epiphysis would be the most proximal, then you get the physis, then the metaphysis, and then here would be the diaphysis. And then a type 5 is a crush injury of the growth plate, and these are the worst to get. All right, so here we're going to talk about some fracture examples. Many fractures have eponyms, those are just names for those fractures. We're not going to cover all of them. And we're really not going to get into too many of the classification systems because there are so many. And even for some fractures, there are multiple classification systems for the same fracture. So if you guys on this one identify fracture location. All right. Let's show this region. That's where the fracture is. We'll go to the next slide. So this is the Salter-Harris 2 fracture of the middle phalanx, or the proximal phalanx of the thumb. So it's right here, and we see this fracture extending to the physis, but it's not in the epiphysis, it's just here in the metaphysis. This one's a tricky fracture because we don't really see it well here on this view. We don't see it well here on this view. We're only seeing it right here. So while we like multiple views for confirmation, sometimes we only see a fracture on one view. All right, so here's another example of a buccal fracture or a Torus fracture. And here we're seeing this buckling of the cortex here, the dorsal cortex, but the volar cortex is intact. This again is a buccal fracture. And these can be very subtle, and these can be missed. If they are missed, luckily, these heal really well. But we still won't want to miss them as much as possible, because nobody likes to be wrong. Here is an example of a Greenstick fracture. We're having this fracture here. We have this bowed, and then we're having this intact surface here. So this is the convex surface, which shows the fracture, and the concave surface, which is bowed with no fracture. So that's a Greenstick fracture. Another incomplete fracture. All right, this is a Bennett's fracture. The Bennett's fracture is a fracture of the base of the thumb metacarpal, right here, the thumb CMC, or first carpal metacarpal joint. And it's an intra-articular fracture. And this is attached here by ligaments, and then we get a little bit of radial displacement of the rest of the metacarpal. And it ends up having a small triangular fracture fragment. This is a Bennett's fracture. And then we also have what's called a Rolando fracture. So this is similar to the Bennett's fracture, but instead of just one fracture fragment, we have a comminuted fracture with a Y-shaped intra-articular fracture at the base of the thumb metacarpal. So right here we have the same fragment. So if we just had this fracture fragment, it would be a Bennett's fracture, but then we have this other fragment, which is more radial base of this metacarpal. So then we call this the Rolando. And this is one of my favorite fractures because it's Y-shaped. Now we've got a boxer's fracture. We've already talked about it. So here we have this fracture of the neck of the fifth or ring finger metacarpal, and it shows this apex dorsal angulation. The next fracture is the Colles fracture. This is one of our most common fractures that we see. This is an impacted, displaced fracture of the distal radius with dorsal tilt of the distal radial articular surface and apex volar angulation. So when we're talking about tilt of the radial of the articular surface, that's just for the surgeons because they want to know if they need to go in and or how much they need to reduce it when they're doing reduction. Normally, the risk of volar tilt or neutral.
Can I ask a question?
Yeah.
When you're looking at these lateral risk radiographs, how can you tell what is anterior and what is dorsal?
Good question. The thumb is one way, and then also just the way the bones are going here. And then you can also look. So in the carpal, there's nothing volarly or posteriorly, I should say dorsally, right? So it kind of has a convex kind of appearance to it. And then when we're looking the volar or anterior, right here, we have the trapezium at the base of the thumb, and then the scaphoid projects here. So it goes from right here is the proximal part of the scaphoid, and as we go distal, it goes more volar. That's a good question. Really, I look at the hand, and that helps guide me as to what's volar and what's dorsal.
Thank you.
Yeah, you're welcome. If there are any other questions, you can people can speak up or give a chat. So, all right. So, question on this is: what's the most common cause or most common mechanism of injury for a Colles fracture? Yeah, I didn't say, so this is just seeing if anybody can guess what's right. All right, so the correct answer is a fall on an outstretched hand, which could happen in a sports injury, but really we talk about it as a foosh, F-O-O-S-H. So a fall on an outstretched hand is the most common mechanism of injury for a Colles fracture. All right, so this is a Smith's fracture, and this is basically a reverse Colles fracture. These are not common because almost everybody falls on their outstretched hand. And the Smith's fracture comes when you fall on the back of your hand or on the dorsal aspect of your hand, which then causes to have this volar displacement, and not common. So on a Colles fracture, this part of the radius goes dorsally, and a Smith's fracture it goes volarly. So here on this hand, it's nice because we can always tell what's volar and what's dorsal because there's the thumb. And then we have a scaphoid fracture. These are some of the hardest fractures to identify on radiographs because if it's non-displaced, you might not actually see it just because of the way the bone is in its course and how it's laid out in the wrist. So this one we can see on this view right here. We see this disruption of the waist of the scaphoid, but on this view it's harder to see. So a lot of times as radiologists we'll say we don't see a fracture, but if there's pain in the anatomic snuff box, to splint it and then get repeat radiographs in 7 to 10 days or 10 to 14 days. Because usually after about 7 to 10 or 10 to 14 days, we start to see fracture resorption. And so in the healing process of the bone, we actually get resorption at the fracture line before we produce new bone. So this would get more apparent because the line would get bigger. The reason why this is an important fracture is because it has a blood supply that comes here to the distal pole, and then a blood supply that comes to the waist right here. And if this fracture becomes displaced or moves too much, even if it's non-displaced, you can cut off the blood supply here at the waist, and then the proximal pole of the scaphoid will not get blood, and then it'll have osteonecrosis and become non-viable bone. So it's better to err on the side of caution in this and splint somebody who has an occult fracture or one where we don't see a fracture and there's a concern of it, because worst case scenario, they get osteonecrosis of the scaphoid. Best case scenario, we splint it when we don't see it, and then the bone heals. And then, if we're splinting somebody who doesn't have a fracture, they're just going to have some limited motion. But in reality, the consequences of not splinting are worse than having somebody have decreased motion if they don't really have a fracture. That's a scaphoid fracture. The next fracture, this is a tibial and fibular spiral fractures. These are fairly common. And then here we have a tibial plateau fracture, and this has multiple classification systems that basically describe fracture planes. So here we've got this transverse or longitudinal fracture here. Here it's intraarticular coming here. We see this lipohumerarthrosis with the fat, and then the blood and fluid right here. So the three layers here, 1, 2, 3, lipohemarthrosis. So that's a tibial plateau fracture. Here's a proximal femoral fracture. Here we're seeing this fracture through the intertrochanteric proximal femur. So when we're talking about femoral fractures, we have femoral head, femoral neck, and then the intertrochanteric region. And that region is between the greater trochanter and the lesser trochanter. So on this side, greater trochanter, lesser trochanter, femoral neck, femoral head. So this is a comminuted fracture of the intertrochanteric proximal left femur with apex lateral angulation. And then we have displacement of the lesser trochanter. Now, if we see just an isolated fracture of the lesser trochanter, it's metastasis or a malignancy until proven otherwise. So if all you see is a displaced lesser trochanteric fracture, there's a malignancy. This person has a big fracture comminuted, so then we're not worried about that in here. And then in the ankle, this is the only classification system I'm going to talk about, and this is the Weber classification. And this is a Weber A. And the Weber A is a fracture of the tip of the lateral malleolus. And it's usually just an avulsion fracture from the lateral ankle ligaments. And then we have a Weber B. So Weber B fractures are oblique fractures of the lateral malleolus or distal fibula, extending to the level of the tibio-talar joint. And then you usually get a lateral displacement and sometimes a little posterior displacement of this fracture. So this is a Weber B. It's the fracture that goes to the joint. A is distal to the joint. And then C is proximal to the joint. This may or not actually be a Weber C. What we want to see is it of the distal fibula above the level of the syndesmosis. And the syndesmosis is usually from here to here. But we don't see Weber C's all that common. So this is the best example I could find. And while we're saying it's a Weber C, probably is a Weber B. That's an oblique fracture of the distal fibula. We want it to extend to above the level of the distal tibiofibular syndesmosis. And then here we have a trimalleolar fracture. A trimalleolar fracture is a fracture of the medial malleolus, the lateral malleolus, and the posterior malleolus. So the tibia has the medial malleolus here, and this is the fracture there. We're seeing it here. The distal tibia also has the posterior malleolus, which we see on the lateral view, and right here. And this is this little fracture fragment here. Depending on where you are in the country, how it's described varies. Here at the University of Utah, any fracture that involves the posterior aspect of the tibia, we are calling trimalleolar fractures or posterior malleolus fracture. Or I did my residency in Milwaukee at the Medical College of Wisconsin. If it wasn't a large fracture fragment involving the posterior malleolus, we didn't call it a trimalleolar fracture. And then here we're seeing this fracture of the lateral malleolus or distal fibula. And then here's a radial head fracture. So statistically speaking, in adults, a fracture of the elbow with an elbow joint effusion with the anterior cell sign here, an elevation of the posterior fat pad here is going to be a radial head or radial neck fracture. It's going to be your most common. So this one we see here on the AP view involving the radial aspect or lateral aspect of the radial head. You see it on the oblique view here, and then we see the joint effusion here, but don't really see the fracture well on the lateral view. And then in pediatric patients, statistically speaking, the most common fracture of the elbow is going to be a supracondylar fracture. And that's going to be through here, through the supracondylar distal humerus. We're seeing this fracture line here and here. And this patient has a very large joint effusion. This posterior fat pad is really elevated. Normally, you shouldn't ever see a posterior fat pad because of the olecranon fossa. So that fat sits in the fossa. And then here's the anterior fat pad sign, or the anterior cell sign or spinnaker cell sign. So the reason we're looking for fat being moved is because the blood moves the fat pads away from the joint as the joint capsule fills with blood. And then here is a mid-clavicle fracture. So this is a Greenstick fracture of the mid-clavicle. It shows this apex cranial angulation. Here's the convex marginal fracture with a fracture line. Actually, this is a complete fracture. I'm never calling it Greenstick because there's fracture right there. This is a complete fracture of the mid-clavicle with apex cranial angulation. And then here we have a Lisfanc fracture dislocation. So these are becoming more and more known by people just because of sports injuries. So what we see here is the right foot. These are weight-bearing radiographs. You're concerned for Lisfanc fracture, you need to get weight-bearing radiographs. So here we see this is the Lisfanc interval. So this is the medial cuneiform, the middle cuneiform, and the lateral cuneiform. Base of the first, second, third, fourth, and fifth metatarsals. So the fourth and fifth metatarsals are here on the cuboid. The third is on the lateral cuneiform. The second is on the middle cuneiform. And the first is on the medial cuneiform. And this is the Lisfanc interval. We don't want it wide, and we want to see that the base of the metatarsals line up with their midfoot bones here, with the cuneiforms and then the cuboids. So on the left side, so we got the right side to compare to the, so we can compare for the left. Because here we have a fracture of the base of the second metatarsal here, and then there's a fracture here of the third that we don't see well on this AP view, or PA view. But what we're seeing is that there's widening of this interval right here, this gap between the first metatarsal base and the second metatarsal. So that's a Lisfanc widening, and then we see that this starts moving this way. So the base of the second and third metatarsals are moving laterally with respect to the cuneiforms. So we call this a homolateral Lisfanc fracture dislocation. That's how we describe this. And in Utah, probably there's been quite a few football players, and probably all the schools have had it. Probably one of the more famous recently has been Taysom Hill for BYU, who injured his Lisfanc ligaments against Nebraska in 2015, which was sad for BYU fans, including myself. So there are three ligaments in the Lisfanc. There's a dorsal, an interosseous, and then a plantar, and the interosseous is the strongest. And you can have tear of all three ligaments or not. So that's the Lisfanc fracture. All right, so here's the quiz questions. I'll just have you email Serena with the answers. So I'll just show these three slides, or these three questions for a few seconds or a few minutes. And then there's one more slide with the other two questions. All right, I'll give you 15 more seconds, and then I'll go to the next slide. All right, and the last two questions. I'll just give another 20 seconds.
Hey, the slides did not update on my screen. I don't see the second set of questions.
Oh, that's weird. Why isn't that working?
It just worked a second ago. I don't know what you tried.
I'm just clicking through, so I'll go back. Maybe it's going slow.
There it is. We see it.
Okay, I'll leave this here for a minute. All right, and if you guys have any questions about fractures, you can email us or email me. It's usually pretty simple, but something that you'll need to know at least a little bit of. I know we're all enjoying this as best as we can, but we're happy that you guys are doing this course so you can at least get a little bit of exposure to radiology no matter what you're going into. And hopefully it's been good. Does anyone else need more time? All right, not. You don't need to do that one. All right, so this is my references, and thanks, and hope all goes well with you guys with COVID-19. I hope some of you consider radiology. So with that, I will stop recording and get this to the next presenter.